It's a pleasure to be here with you all today. We'll be talking about autism, ADHD, and executive functioning, reviewing diagnosis and treatment. Throughout each of the above, we'll also talk about developmentally what to expect at each level. In terms of autism, as we know, autism occurs quite frequently in the population and cross-cuts racial, ethnic, and socioeconomic groups. It's 4 times more likely in boys than in girls, and average prevalence is between 1% and 2%. In the United States, we see autism occurring in 1 in 47 children. In terms of autism, with the latest DSM-5 text revision reviews, we did not see much change to the diagnostic criteria. So what we are looking for in terms of symptoms related to autism are deficits in social communication and social interaction across multiple contexts, so not just in one setting. In addition to that, a restricted, repetitive behavior, interests, or activities. And with the DSM-5, this also includes sensory sensitivities. We expect the symptoms to be present early in the developmental period, and as we saw with the transition from DSM-4 to DSM-5, the autism spectrum, removing Asperger's syndrome from the diagnostic criteria, and rather including it in the spectrum as a whole. So when we think about the social communication component of the symptoms of ADHD, we see a lack in social emotional reciprocity, that back and forth communication, the nonverbal cues. The child may not be interested or engaged or able to engage in that communication. In addition, they have poorly integrated verbal and nonverbal communication, oftentimes a lack of eye contact or fleeting eye contact, an abnormal use of gestures, potential use of another's hand as a tool to grab what they need, and a lack of facial expressions to express their emotions. This results in long-term difficulties developing, maintaining, and understanding relationships and social connectedness to one another. Now, in addition to that social communication category in the DSM-5, we also see stereotyped and repetitive movements. That could be head banging, rocking, flapping of hands. Oftentimes kids will have a bigger response to different situations. Echolalia, repeating what someone else has said, repeating back parts of scripts from movies or television shows that are of particular interest. And again, those restricted repetitive movements. These children also are having an insistence on sameness, having difficulty with changes in routine, needing to have those established routines and ritualized patterns. Those restricted interests, in addition, are a huge component of this category, where we're looking for children to have an interest in one particular domain and have a difficult time being able to move away from that category when they're asked to in conversation. This can include things like trains, dinosaurs, space, different aspects of water animals, potentially having fish. I have a few patients who have a specific interest in fishing and know every type of fish, how to catch every type of fish, which bait to use, etc. And in addition, in the DSM-5, we added the sensory input component as well, so they may have a hypo or hypersensitivity to any type of sensory piece. So that might mean tags in our shirts, our socks have to be just the right way, textures in our mouths, loud sounds, things like that. So as we talk about the DSM-5, again, we moved away from Asperger's syndrome being part of the diagnostic criteria in the most recent edition, and this stayed for the DSM-5 text revision. So when we're making a diagnosis and you have sufficient number of symptoms in the category we just discussed, then we would also expect to see a diagnosis that includes additional criteria. This is what I have listed here. With or without a specific intellectual impairment, with or without a language impairment, if there's an associated medical or genetic condition, and then with or without another neurodevelopmental condition or catatonia. So if you're making a diagnosis, you'll be doing autism spectrum disorder with or without intellectual disability, and then with or without language impairment in order to have the complete diagnosis. In addition to that, in the DSM-5, we outlined levels of severity. So now when you're making that diagnosis, you also want to think about the level of severity for each component, social communication and restricted repetitive behaviors. Level 1 will be the most mild of the autism spectrum behaviors. all the way to level 3. And I won't repeat everything for you here, but level 3 is what we typically think of in the most extreme autism cases. Shaking, completely nonverbal, lots of rocking, lack of engagement with others. So when you're making that diagnosis, as I said, you have the autism spectrum disorder, with or without intellectual impairment, with or without language impairment, and then that level. So potentially, if it's a mild case, level 1 in terms of social communication. Maybe if they need a little bit more support with restricted repetitive behaviors and interests, you might do a different level if those symptoms are more severe. In terms of diagnosis of autism, the ideal from an evidence-based perspective is to have a psychologist, developmental pediatrician, speech and language pathologist, occupational therapist, and ABA provider all together. Now we know for access that can be incredibly difficult, and so ideally having at least a psychologist or developmental pediatrician identifying these symptoms, providing the evidence-based measures is most effective. At Johns Hopkins All Children's, we have this clinic in place where we see all of these kids in one day through all of those providers. So they get to meet with each of those providers during the course of their clinic appointment. In addition, have the opportunity to be evaluated by each of them so that we can meet together, review the case, determine the most appropriate diagnosis under each of those criteria, and then what recommendations we might provide. In terms of recommendations, what you see here are the most significant recommendations we want to see for any child diagnosed on the autism spectrum, including speech and language therapy, occupational therapy, applied behavior analysis, and then follow up with medical specialties. This, of course, includes neurology, all of you in this room, genetics, potential for a sleep study as well, as we've noted in the previous talks, the importance of sleep and its relationship to autism as well. And then with ongoing follow-up and treatment monitoring. So that's a very quick overview of autism because we also have a short time to also cover ADHD. And this is really personally where my passion is in terms of ADHD and executive functioning. So again, as I noted back in March, the DSM-5 had released a new edition. This is the DSM-5 text revision. We do see continuing prevalence of ADHD. It is one of the more prevalent diagnoses for our children and youth. 6 to 9% of children and 4 to 5% of adults continue to meet criteria for ADHD. And this tends to be higher in medically complicated populations, such as those that you see, of course, epilepsy, genetic concerns, having any sort of developmental challenge as it relates to your birth history. ADHD is also more frequent in children, of course 2 to 1 in children and 1.6.1 in adults in terms of a male to female ratio. So we do see this more commonly diagnosed in males, and females are more likely to fly under the radar and present with an inattentive presentation. Now, with this in mind, a recent study demonstrated that for children who are young for their grade, in kindergarten, are more likely to be diagnosed with ADHD than older kids. So if you are seeing a young child who is just starting school, having a lot of behaviors, and they might be young for that grade, we want to monitor that closely to make sure that we are providing them the most appropriate diagnosis and not just looking at developmental maturity. So as we move to diagnostic criteria, what we see here in the DSM-5 and continuing in the DSM-5 text revision is that symptoms must be present prior to age 12. This is a change from DSM-4. They must be evidenced in 2 or more settings. So that is oftentimes for our children in the school setting and in their home setting. And for the inattentive set of symptoms, we expect to see 6 or more symptoms that persist in the past 6 months, again, obvious before age 12. And then for older adults and adolescents, if we are diagnosing older in life and they have had early noted concerns, they only need to meet criteria of 5 of the symptoms. This also has to clearly impact their school and vocational settings and their performance in those settings. In terms of hyperactivity and impulsivity, they have to again have 6 or more of those symptoms for 6 months prior to age 12, and then for older adolescents and young adults, 5 symptoms need to be necessary. Again, it has to be clinically impairing their ability to perform in the environment. When we talk about inattentive symptoms, this is the list here. So again, we want to have at least 6 of these when we're making a diagnosis. That includes the ones we typically think about. Difficulties maintaining attention and focus, doesn't listen when spoken to, doesn't follow through, has significant difficulty with organization, avoiding tasks, avoiding things that require focus and concentration, frequently losing things, forgetful in daily activities, and failure to give close attention to detail. Now, when we think about these, parents often come to me and say, my child has a memory problem. It's incredibly rare for kids to have memory problems unless they've had a traumatic brain injury, radiation therapy for chemotherapy, or something like that. So more often than not, when a parent comes to me and says they have a memory problem because they're not remembering what tasks the parent asked them to do, they're not able to follow directions that are more than 1 or 2 steps, then oftentimes that is because of inattention as opposed to a specific memory impairment. Now, when we continue on to hyperactive impulsive symptoms, again, we're looking for 6 of these. So fidgeting, tapping feet, squirming, that constant moving, having difficulty staying seated, almost run by a motor, has to go, go, go at all the time. Running and climbing, unable to play or engage in activities quietly, maybe moving from toy to toy, leaving a mess behind them. The parents can see everywhere that they were in the room. Talking excessively in the classroom, blurting out answers, maybe being the class clown, having difficulty waiting their turn, and interrupting or intruding upon others. So really important to be thinking about for those 12 and under, identifying the 6 symptoms from here. And as we moved again from DSM-4 to DSM-5, we also had a change in the diagnostic criteria that we'll talk about. Now, I personally find this table really helpful when you're talking about school-aged versus adolescents, because for our younger kids, you're really more likely to see those hyperactive behaviors, and the impulsivity changes as they reach those teenage years. So what you can see here is just that transition. We're going from having that hyperactivity, the difficulty staying on task, that talking excessively, to more difficulties with executive functioning skills as they reach adolescence, and more difficulties being able to stop and think before making decisions that can be quite impactful. So when we're talking about the different classifications of ADHD in the DSM-5, again, we moved away from what we used to call ADD. So many parents and families are very familiar with that ADD diagnosis. But as we move to this new criteria, ADD no longer exists. When we talk about ADD, it's really renamed as Attention Deficit Hyperactivity Disorder, predominantly inattentive presentation. Now, you can also have ADHD, predominantly hyperactive and impulsive presentation, where the child has a lot of behaviors, hyperactive and impulsive, but is able to maintain attention that whole time. So they may be walking around the room quite actively, and then they're able to take in all the information that's been presented to them. Now, traditionally, we also have what used to be called combined type, now combined presentation of ADHD, where you have the inattentive and the hyperactive impulsive components. Now, from there, you can also further specify by impartial remission or by level of severity, mild, moderate, or severe. We have 2 other classifications we also use for children who have medical complications: an other specified ADHD if they have some symptoms, but not all to meet the criteria, but continue to need support and treatment. And then an unspecified ADHD where the clinician does not yet have additional information, but would like to start treatment. So as we talk about ADHD and we talk about the movement to adolescence, we also see the significant executive functioning deficits. And provided here is a list for you all of each of those subdomains of that frontal lobe development. Oftentimes, as a neuropsychologist for testing, we're not testing for executive functioning prior to 8 or 9 years of age because that frontal lobe is continuing to develop. But here you have all of those different components of executive functioning: the initiation, inhibition, shifting, difficulties with planning and organization, self-monitoring, being able to stay on task, emotional control, and then working memory, that short-term memory. Can we keep information in mind while problem solving? So what we saw from the NIH, about 20 years ago now, was that continuing development of the frontal lobe all the way through to age 25. And we know that this is delayed for our children with ADHD as well. So executive functioning skills continue to be a challenge for them all the way through the mid-20s, but also they may develop fewer and less efficient executive functioning than their peers. From 3 to 7 years of age, we really do start to see the prefrontal cortex developing. We are seeing increased gray and white matter densities, increased metabolism in those zones as well, and the density of the neurons in the dorsolateral prefrontal cortex is only about 10% above the adult levels by 7 years of age, so we're also seeing some significant trimming during this time. For these younger kids, what we're really looking at is beginning development of attention span, working memory skills. Are they able to be cognitively flexible? And are they starting to take on that perception that another person may have another view? Again, that perspective taking and empathy. As we continue to 8 to 12 years of age, again, we continue to see the increased white matter and the streamlining of the neurons there, that second wave of cortical development, and from a neurocognitive perspective, maturing of their cognitive flexibility, improved inhibition, vigilance, and sustained attention by age 11, hence the diagnosis being onset of symptoms prior to age 12, and then gains in working memory and strategic planning. From 13 to 19, we see continued brain maturation, increased myelination in the prefrontal cortex, and achieving those adult levels that we would expect to see as they head into their late 20s. Acetylcholine reactivity peaks during this time as well as they head into young adulthood. And as we head into the late teens and early 20s, we really are looking at improved attentional control, improved processing speed, mature inhibition, and gains in working memory skills overall. So as we think about these things, as we see our children and adolescents in clinic, incredibly important to be supporting them, not only from the attention standpoint, but also from their executive functioning. So if we're thinking about attention alone in our younger kids, making sure that we're providing recommendations. We know that the most effective treatment for ADHD from a number of studies is a combination of medication management of symptoms, home recommendations, and educational supports. So one of the things I talk to our neurologists about at Johns Hopkins is to have these recommendations ready to go to give out to families to best support them in their different school settings. For our children within attention, making sure that we're redirecting them back to the task at hand in the classroom, making sure to cue them for any changes in behavior, rewarding positive behavior, and then redirecting their attention back to task quietly. We also want to make sure that we're establishing eye contact, providing instructions in short statements so that they can understand what's being presented to them with few words, and then also requiring them to repeat back the instructions. In addition, for many of our kids in the homework domain, we're asking for shortened assignments, modified assignments, so that they are able to focus for a certain amount of time rather than taking 2 or 3 hours to do homework that's repetitive and continuing to demand attention span that they don't have late in the day. In terms of executive functioning skills, really making sure that our schools are helping our kids to set up plans for how to approach tasks. Something like a book report or a big project can be quite overwhelming if we have executive functioning deficits. So breaking that down into smaller pieces, setting a timeline to that with rewards, so that we can ensure our kids are taking in the information, able to utilize those skills slowly over time to have planning and organization themselves. That's something that's going to be scaffolded with the parents. Effectively teaching note-taking skills, I'll show you some great apps and software for that as well. And then making sure that we're using organizational tools such as calendars. Much of this is much easier now that we have a very significant number of apps available to us to best support our kids. I wanted to provide you some of my favorite books here as well for executive functioning skills. There's also Spanish versions of these for families. They can take quizzes at the beginning of the book to determine where the biggest challenges are for the kids in the home, and then that directs them to the specific chapter that's going to be most effective. In addition, here are some of my favorite applications to be used on their phones. Cue Card is a great opportunity for alarms, reminders in terms of assignments, happy goals if we're setting some SMART goals and working towards them with rewards at home, student planners, and then Draft Builder and Co-Writer on donjohnston.com are really quite fantastic because they break down this information for our kids. They allow them to outline a report, be able to use keywords, set up the introduction or the thesis, the middle and their conclusions, and do that in a really effective way. We also now have a number of smart pens, so our kids with ADHD can be recording a lecture in the classroom while taking notes and a special notebook. And when they need to go back to the part of the lecture at which they took a specific note, they can tap right on that word or that set of words from their note-taking and be able to pull up that part of the lecture on the smart pen that's been recorded. So in case they miss something, they can double check what they've done. Thank you all so much for having me here today. It has been a pleasure to speak with you about ADHD and autism, and I look forward to meeting you all throughout the conference. Thank you.